Welcome to Live from Plato's Cave. I am Mario Veen. This is episode 18, How Doctors Think with Camillo Coccia. I don't know if I told you this already, but my day job is currently in medical education research. I'm fascinated by the correspondences between philosophy and medicine. For instance, there's a certain innate violence in medical thinking, but at the same time, this is the kind of thinking that allows us to live longer and healthier lives. Medicine is full of these kinds of paradoxes. That's why I was so happy when I met Camillo Coccia a few years ago, because he's a doctor who also studies philosophy. Camillo is a medical doctor from South Africa. Currently, he works as a senior house officer at Letterkenny University Hospital Department of Hematology. He has a special interest in existentialist philosophy, German idealism, and phenomenology. We published a paper together called Because We Care, a philosophical investigation into the spirit of medical education. We discussed that paper at length in another podcast, which I will link in the show notes. Camillo also published a book chapter with Sven Schaepkens called In Pursuit of Time, an inquiry into kairos and reflection in medical practice and health professions education. Thank you for speaking with me.
Yeah, it's not our first time.
No, we've had many conversations. So I know it's your holiday now, but before your holiday, what does a normal day look like for you?
Well, so I have done quite a few different medical jobs, as it were, from emergency medicine, radiology, general practice, clinical research, and now I took a dive back from clinical research into clinical medicine. So I work at the Department of Hematology at Letterkenny University Hospital in Ireland. So it's a really busy job, mostly treating, really unwell patients with hematological diseases, which mostly comprises of different types of, blood cancers, leukemias, and lymphomas, generally treated with some or other chemotherapy agents. So we work closely with the oncologists in a way, but we fall sort of between oncology and medicine. So day to day is managing patients with those sort of illnesses and disorders.
Most of those patients, do they have any chance of getting better?
More and more. So, when I worked in South Africa before this, we would see quite a lot of those sort of malignancies, and in a way, especially diseases like multiple myeloma. We were introduced to that in South Africa. It was kind of a death sentence. There was only one line of treatment, but it's just an exploding kind of field. So yeah, people get better and people stay better for longer now. Mm-hmm. Some of the diseases they come and go. They're not tumors that we can get rid of completely, but people live long lives with quite nasty illnesses.
Are you able at the end of the day to just let everything go? Like if, for instance, a patient died or something went wrong?
Well, we're here in Europe now. Patients don't die quite as much. So when I was in South Africa, South Africa's history, of course, is inseparable from, colonialism, apartheid, or apartheid, depending on how you say it. And the third thing South Africa's history is inseparable from is HIV. Mm-hmm. So the recent history of South Africa is really a medical history, because so much of the country died from HIV. So, and we're still seeing the effects of that. So when it comes to deaths, was something we would that was routine for us. I think I remember when I was an intern, we would sign off on 2 or 3 deaths every night, some nights. So it's something that, in a way, you learn to let go at the end of the day.
And how come so many people died in South Africa of HIV when it's perfectly treatable now?
I mean, if if we had the answer to that question, we wouldn't be doing it. But so there's a lot of things that happen in South Africa. So I know everyone's seen the Dallas Buyers Club, and has an inkling of the the target drug in that movie is a zidovudine, AZT, and it was given on its own to treat HIV, and it worked sometimes, but it had horrible side effects. And the next treatment that came out was nevirapine, which was safe to use in children. And due to some very weird situation, there was a bit of Russian misinformation that was going around that HIV does not cause AIDS. So the progression of the syndrome from the virus was not correlated. And our president, around 1998, 1999, that sort of time, he kind of fell prey to this. And he was an economist, and he was trained in Russia. And he said that, look, yes, what's factually true is that people with HIV seem to progress to AIDS much faster if they're eating unhealthily, they're poor, which was the information he had at the time. And so he absolutely flatly refused to roll out antiretrovirals. So we only had antiretroviral rollout sort of 5 to 10 years after most Western countries. And by that time, I think about 20% of the population was affected by it. So what's interesting is the sexual practice of communities that are more affected by HIV. There was obviously quite a lot of propaganda around that it was, a kind of punishment for sexual promiscuity, but and that Africans were more sexually promiscuous than white Westerners. But while it depends what you mean by promiscuity, because if you look at the absolute amount of sexual partners between the racial groups, they're pretty much the same. But white Westerners tend to have serial monogamy, whereas Black Africans tend to have multiple partners at the same time, but for longer periods. So that kind of sexual practice led to huge HIV numbers, and we're still not catching up. So, ARVs, we're trying to reach millions and millions of people. I think it's about something absurd, like 14% of the population or 11% of the population that's affected by HIV. So it's massive, massive amounts of numbers, and obviously it keeps spreading. So we still have people dying. We still have people who can't access medication because they can't transport to clinics, or they prefer to use witch doctors to treat the disease. I mean, I'm no expert in this, and there are experts in this. So the problem is so multifaceted at the moment because of just the sheer quantity of people affected. That's what we were stuck with. So when I joined medicine, it was when did I graduate? 2016 was my first year. Things had already got a lot better. But before then, sort of around 2000 to 2005, around that, it was complete chaos. It was absolute people dying in huge numbers of curable infections in, say, a person with a normal immune system, but things that we couldn't really do anything about if you have advanced HIV.
In the beginning, you connected this to some Russian information in the 1990s, I guess?
Yeah, I'm not 100% sure about that, but I know that a lot of the post-Cold War kind of information wars that were going on at the time included a lot of Russian intelligence versus CIA, disinformation campaigns, and whether those were targeted at the enemy or their own people to make them believe that, where the enemy was the decadent West, or the enemy was the oppressive Russians. I'm not sure, but I know that the connection between South Africa and Russia is quite strong because of the communist support of the African National Congress during apartheid. And these things kind of leak into each other. And the HIV does not cause AIDS. How do we say? Yeah, misinformation was quite a Russian idea at the time. I'm not sure myself how precisely it went, but I was reading quite a bit on it at the time, and it seems like there's quite a strong link there.
All right, so it sounds like you're spending your days quite usefully if you're taking care of people who are suffering with cancer and other types of diseases. So do you have any time for philosophy? Why would you spend time on philosophy at all?
You're right. I have less time now than I did. I think when I chose to start doing medicine, I didn't know what I wanted to do. I think I was quite stuck, and I remember it quite vividly in my final years at school, not knowing what to do, and everyone had a sort of idea that they were going to study this or that. And I did one of those aptitude tests, and they told me to become a hotel manager or a politician.
Hotel manager or politician, yeah.
Yeah.
Well, I guess those, yeah, you need the same kind of qualities for those.
So I was, that wasn't particularly helpful to me. So my sister's a doctor, and I thought, it's a great and noble profession. But I always wanted to study philosophy. I think I started reading philosophy when I was around 14 or 15. And I didn't really understand it.
That's quite young. How did you start? Did someone give you a book, or?
Well, my father read a lot of philosophy. He was very interested in Nietzsche, and of course, trying to understand Nietzsche without reading anything is almost impossible. So I just knew that at that time that Nietzsche had a lot of issues with someone called Plato. So I borrowed a book from the library on Plato, and it was really understandable in some way, because at the end of the day, Socrates is asking really simple questions. Well, what's justice? What's truth? What is love? Very simple questions, and no one seems to ever have the answer. Least of all, Socrates, who just has more questions. And I think I slowly started understanding more and more as I got older, and I thought, do I want to do medicine or do I want to do philosophy? And that was my question, on the precipice of deciding. And my father just said to me, you can do medicine, and if you do medicine, you can do medicine and philosophy. If you do philosophy, you can't do philosophy and medicine. It's a lot more difficult. which isn't strictly speaking true. If anyone out there is a philosopher listening and wants to do medicine, it's been done the other way around. But I, I understood where he was coming from, and then I just leapt into medicine. So, when I'm talking about how I chose to do medicine, it's very uninspiring. I remember getting to medical school and being in the first year, and everyone's nervous around me, and they kind of G'd us up. They were like, "This is a hard course. It's very difficult. It's very complicated. A lot of people fail, but once you've graduated, it only gets worse. It only gets more difficult before it gets easier." And I just remember, everyone kind of apprehensive. And then the kind of cathartic break at the end of this talk was that, but you've all, medicine is a calling, it's something that speaks from deep within you. And I didn't resonate with that. I didn't choose medicine because of any deep kind of commitment I had. I chose it because I was genuinely curious more than anything. So I felt like I was always a bit of an outsider to this, like being a doctor, wanting to be a doctor, this desire. I never really had that. I was just genuinely curious. So all through my studies, I kind of had in the back of my mind, I want to combine this philosophical thinking with medicine. And I was having such a horrible time in my final 2 years of medicine, very lonely and unbelievably, stressed and under pressure. And I sort of actually was thinking, let me give up on this stupid medical idea, let me get out of this, because I was looking at stressed doctors around me, lots of divorces, lots of, people not seeing their families because they're at work all the time. And then I really started to try and commit to philosophy. So I started researching, trying to develop a thesis to try and apply for a program that could get me out of medicine and into academia. And then when I started working in clinical practice rather than as a student in clinical medicine, I realized that it's actually it's fascinating. Working with people is there's nothing like it, and because for one thing, you actually have a lot more power as a doctor than doctors tend to acknowledge. You're really like trying to decipher a code from the patient's symptoms and signs and investigations. You're really interpreting this code, and then when you pass it back onto the patient, they can completely understand what they've been experiencing in terms of simple kind of causal events. You have diabetes, there's lots of sugar in your blood, the bacteria like to eat the sugar, and that's why you have a pneumonia. That's you can kind of decrypt this person that's slowly been getting more and more short of breath for the last 6 days and is now very sick. And you can tell them that, yes, it's going to take some time for you to get better. And it's to a population in South Africa where the education is really, really low, that you can seem like a magician. And it's very captivating to be in that position. So I really started to enjoy medicine in that way. And also was a very arrogant young doctor. And I had to learn the hard way how not to be an arrogant doctor through some mistakes that were really really unfortunate. And as an intern, and that's when I really started to think this philosophical task wasn't a kind of extraneous escape from medicine, but that philosophy was really necessary to understand medicine itself. what is the position of the doctor? Where do all these questions come from? And why don't doctors seem to have any answers for them? So, that was kind of one of the serious questions I started asking. And I found some answers, and in the academic journals, people who had the same questions as me, but mostly coming from outside medicine, mostly people who had kind of specifically philosophical viewpoints on concepts of health or concepts of disease or concepts of like Foucault and biopower. And then I thought, well, what would it be like to look from the inside? And so that's kind of what I've been doing, and kind of what led up to us meeting in that fateful online course.
So first there were kind of like parallel worlds, philosophy and medicine. And then you found out from your practice that some questions that you had were also like good candidates for philosophical approaches. What can you just say one more time? What kind of questions are you thinking about? Because it seems to me that there's even the CanMats, they call it CanMat roles. Do you know them?
No.
I don't know if they can list them all, but it's basically a diagram of all the roles that the doctor should play. So at the center is obviously medical expert. Then there's communicator, scholar, and a bunch of other ones. You can look them up, but philosopher isn't in there.
Oh, and or should it be?
So let me make my question more specific. What if you think about doctors, they need to, of course, they need to be able to diagnose diseases. They need to be able to do like the physical tasks that you need to do, like operating, or you need to be able to speak with people, to listen to them, like have some communication skills, to put it that way. So where does philosophy come in there?
Yeah, I mean, that's almost the perfect way to ask the question. And I think it's perfect because that's exactly how a doctor would ask it. Because a doctor would look at all these things, these concrete tasks that they need to complete every day. I need to make the diagnosis, I need to make the treatment plan, I need to communicate. And in a way, once you've set all those tasks in place, what is outside this? How can philosophy enter? Why the need for philosophy? And ultimately, that's the interesting question, because philosophy, what it comes and does is it kind of undermines all those tasks. Why do you say you need to be a communicator, right? Obviously doctors talk a lot, but surely communication, includes diagnosis, because you're already forming a language when you're making a diagnosis. That's really what you're doing. So when you're formulating a diagnosis, you're really creating a sort of mathematical problem in a way. And A plus B tends to equal C, and can also include all these other things. And that's how we think about it. In medicine, we're like, great, we have this sign and this symptom, and it equals this disease. So in some way, that is a language. That is the creation, that is a communication of a language. But when you really enter clinical medicine, you find that the logic is kind of different, and that we communicate in a different way. We include within these kind of positive signs and symptoms, we include these incredibly interesting negative assertions. So for instance, this patient is a patient with something rare, an aspergilloma, or a pulmonary abscess that is not diabetic. So, we'd expect this in a diabetic person. This person is not diabetic. So immediately you're in this kind of a different realm of language, which is which is includes negatives, which is not how we're really taught in medical school. In the beginning, you're expecting a lot of this plus this equals this, but it's really this plus the negative of the negation of this negative.
So you're paying attention to what is not there.
Yeah.
For instance, you would say, okay, I see this patient with symptom A, and if it would be, I don't know, diabetes, I would also expect to see symptom B, but I don't see symptom B, so maybe it's the next one on the list. It's kind of a logical reasoning, diagnostic reasoning. I'm giving a workshop tomorrow on abductive reasoning, but that's perhaps for another time. But you're using induction, deduction. You're using the rules that you know of medicine, like people with blood pressure over this amount have a higher risk of this disease. So if you see that blood pressure in combination with this other symptom, then they might have this. So you might, I don't know, in this case, try first some paracetamol.
Yeah.
Or take this other test, like, okay, if their blood pressure is like this and this, okay, maybe we need to do a brain scan or something. So it's kind of a way of reasoning, right? And you're communicating with the patient.
Yeah, you're formulating it in a way that kind of, in a way, I was always expecting medicine to be a bit more scientific, that you would collect all the evidence and come to a diagnosis. But really, in some ways you're presupposing a diagnosis. You're saying, this patient is very short of breath, and they have very swollen feet. They probably have some degree of, their heart is involved, and this is some heart failure, in a broad category of disease. And so you work from there and say, okay, let's search for the evidence to group all these things together so I can prove that is the case. Naturally, the secondary thinking is, we need to make sure it's nothing else as well for safety reasons. So that sort of that kind of comes afterwards.
And if you have a patient with a headache, you could prescribe paracetamol, and they could get rid of their headache. But what if they have a brain tumor or whatever causing it? You don't want to just give the paracetamol when maybe there's an underlying other thing that you don't see.
Yeah, and the kind of thinking that would get you there is, well, say this patient's headache is not a normal headache. It just doesn't seem like all the other headaches I've seen. Yep. Or they're coming back for this headache over and over again. Maybe it's worth doing a scan. So it's the logic in medicine is not scientific. I think that's the point I was made. It's not a classical scientific formal logic trying to gather all the information, because sometimes you need to work with what investigations are available. You can't just MRI every patient with a headache, otherwise you would just never have space on the MRI machine. So there's this very interesting logic at play in medicine, and it's passed down from senior to junior, and is very particular to each discipline. So the logic of a surgeon is very different to a logic of an orthopedic surgeon, which is very different to a logic of an oncologist, which is completely different from the logic of a pathologist. A pathologist sitting in a lab looking at a microscope thinks completely differently to an orthopedic surgeon. But ultimately, they're focused on the same thing, which is diagnosis, treatment, and follow-up. Making sure that this person does get better. And so, what was really, this part of the diagnostic thinking was really, I'm not particularly interested in the thinking that leads to it, and how precisely the language is formulated. I'm not a linguist. I'm not. I haven't studied much philosophy of language, but I think that's what really opened up medicine for me to ask, philosophical questions. Ultimately, I think these are philosophical questions. How is it that the logic of medicine works? But what really interested me is how medicine tended to exclude certain considerations, and why particularly those. So, for instance, we had, obviously very tragic cases of multi-drug resistant tuberculosis. And these cases tend to come from patients who take sort of a short course of their treatment and then stop taking their medication for whatever reason. So we have a lot of tuberculosis because of our HIV issue. And so they tend to go hand in hand. Now, when we would see a multi-drug resistant TB, we would, we had a lot of treatment options available, but it was very easy to start someone on multi-drug resistant TB therapy. It's, 7 different drugs, so I can't remember what the 8 different drugs, including an injection that needs to be taken every day. And the question of why this person didn't take their medication, always came up. They would either be too poor to get to the clinic, or there was too much violence in the area that they worked or lived, so that they couldn't get to the clinic. Some of them were working jobs, and it would take a whole day to sit for their medication every month, and they couldn't get more, that amount of leave per year. They could only go every second month. So it was these, obviously drugs, everywhere. If you're on drugs, you're probably not taking your medication. But the point is that these, and especially in the junior doctors, this is not amongst the consultants, the more experienced consultants knew how to kind of tackle these things. But in general, the doctors would tend to focus on what's happening inside the hospital. So very meticulously noting, exactly what's happening to the kidney function, and precisely how the TB is responding, and, exactly all these very particular things about the tuberculosis. But it was almost impossible to consider, what about these social determinants, because at the end of the day, the doctors didn't have control over that. And so that was fascinating for me. What is included in medical thinking? What do we tend to focus on? And why are all these really, sometimes crucial things kind of excluded? And I think that's what really started asking the question that led up to us meeting. What are things we call care? Why is that question excluded? We seem to focus on health, and we completely exclude this thing that we call care. We sort of assume we know what it means, but we don't make that assumption about health. We're intensely focused on what health means, but why do we exclude the question of care?
Yeah, so the question of health, that's one of the things that philosophers do discuss a lot, right? In conjunction with medicine. So is health just the absence of disease, or there are some definitions of health that almost sound like enlightenment, like you feel good, you have a great, you're functioning, everything like that. And where's the boundary between, for instance, someone with chronic pain who somehow found a way to live with that? Is that person ill or not? Is that person sick or not? So there are all these discussions, which, is maybe for another time to discuss. But the question, what is health? Like, I'm thinking back about what you said about Socrates. What is love? What is justice? Well, what is health? That could be one question. What does it mean to be healthy? Is that only physically? Does it also include your mental capacities, your environment and everything?
Oh, absolutely. I mean, that's essentially the modern philosophical question. Is ultimately a hermeneutic one. What is it that you mean when you say X. And what's what that includes is what is all the implicit knowledge contained in this concept, and the philosophical task is to make all that explicit.
Yeah.
And so I when it comes to the question of health, as you say, it's massive. But is it negative? I think that's important. Is it a negative?
Are you healthy when you're not sick?
Yeah,
like that.
Or like the WHO wants us to think is it's a complete mental, physical, social sense of well-being, which is that's a very high bar.
Yeah, can you be differently abled and healthy?
Yeah.
Or so sorry, I just want to go a little bit back, because just to make sure we follow, I follow. So I ask you, so what is philosophy in addition to all those other actually I will share it also, but I can share with you now the CanMed rose.
Oh, okay.
So here we have it. So it's like a flower rose. What's supposed to be what roles should the doctor play, and it's used in medical education. When you teach doctors to be doctors, you should address all of these issues. And in the center, there's medical expert. Then you also need to be a communicator, talk to patients, collaborator, because you're, work with your colleagues and with maybe societal institutions, a leader. Not sure what that means, but okay. A health advocate. So, in the case of HIV or something, it's clear that you need to be a health advocate as well. A scholar, you need to find out the scientific literature, the evidence for what's going on. Professional, which is very vague, but you need to be professional. That's all of them. So then you said, okay, you said that medical diagnostic reasoning or medicine is not necessarily scientific. I think so. Clinical research, like there are lots of people working on treatments for cancer, we can agree that's scientific, right? They're working in a laboratory, they're performing experiments, they're trying to get insights into the mechanisms behind, in this case, cancer, trying to find a cure, something like that.
Yeah, I mean, just from personal experience, that it's quite jarring to go from clinical medicine to research. The shift in mindset is substantial. And that shift in mindset is really present in the ethical problems that medical research poses. I think I was saying a while back that really some of the most horrendous parts of human history have been medical research, obviously from the concentration camps, famously in Nazi Germany, but even the ones that are understated, like in Japan, the medical experiments in southern China. I mean, brutal and unthinking. But in the United States, most interestingly, perhaps, I think, the Tuskegee experiment, which is famously the observational study of syphilis, the study of how syphilis progresses if it's left untreated, which started out with people not knowing the cure for syphilis. But as soon as the cure became widely available in the form of penicillin, they didn't amend the trial. There was no change. And
so they kept observing people with syphilis to see what would happen, even though they could have given them a cure.
Yes. So that when the trial started, there was no cure, or at least the cure wasn't widely available. But it became apparent in the midst of the trial, because it was a long-standing experiment, so lasting many years, that you could cure syphilis, and no one thought to tell these people that we can cure the disease. Now, it's in the training that we got, they actually fairly made it quite clear that it wasn't a malicious thing. It wasn't that the doctors on the trial weren't were malicious, trying to actively harm these people, but it was just this complete thoughtlessness, absolute not considering the fact that it might be ethical to treat this treatable condition instead of letting people die from it. Now, why did that happen is one question. We know what we did to stop it happening again. There's very strict, very, very strict ethics committees. Looking out for this particular thing. But why in science, in the scientific approach to medicine, why was this neglected in doctors? People who would otherwise be trying to treat illnesses were suddenly they forgot. They were trained as doctors, they were doing experiments, and suddenly they forgot to treat the illness that they knew they could treat. So, how did this happen? What was it that was present in the thinking that just allowed for such thoughtlessness? Why were the doctors on this trial able to exclude the whole being a doctor part and were simply focusing on the experiment? And that should be really worrying, very, very worrying. That in medical thinking, we are able to exclude the whole reason we're there. And that is a philosophical question for me to uncover. What is implicit in medical thinking that can allow for this to happen? So I say what's interesting is what's outside. That's what is outside the thoughts of a doctor every day. What are they either consciously or unconsciously excluding in order for this process, these categories of medical thought to continue?
So the reason they can think medically at all, the reason they can learn in medical school how to diagnose patients, and then the patients comes into their consultation room and they can do all that, it's based on something. So in this case, you refer to a historical component, like how did we get this knowledge about the human body? Or very simply, sometimes by cutting people open. But of course, if you want to study the brain, and you rely on, there's an ethical component as well, but you rely on people who are already deceased. Often these were criminals or others. I heard a story that they refer to the brain as gray matter because they used to study it on dead people. I'm not sure. And then when you're alive, because the blood is there, it has another color. Anyway, so if you want to study how a living human being is functioning, you need to kind of incur a kind of violence to this person, even like maybe violence is not the right word, but even what a surgeon does is cutting people open. Well, if I would do that, I would be in jail. I think surgeons joke about this, right? Like, I studied surgery because it's the only legal way to cut people. Anyway, this is one example of how scientific knowledge that we take for granted today, for instance, about syphilis or anything else, is also based on a lot of violation of human dignity in that sense.
I think that's a really fascinating point, and that's a huge part of what I was thinking at the time. What is left out? What do we miss out? And I came across a writing of a gentleman in University of Leeds, I think. I forget his name, but really, it was a challenge to medicine as a whole. Why are people, why are we losing so much empathy in our medical students? So why are doctors becoming less and less empathetic the more they
Yeah,
they
and
go
by the
through
way,
this often.
there's been a lot of research about this, right? About empathy, motivation, things like that in
Oh,
doctors.
absolutely.
Yeah, and many studies conclude that empathy declines, apart from how you would measure empathy. But okay.
Yeah, of course. I mean, but it's kind of secondary to me that uh, how you would measure empathy, because obviously, as in your, I mean, brilliant article, that it, of course, empathy has some kind of internal component, and the more we try and investigate the external appearances of the internal experience, the more we can produce performative, um, behavior, which is, if you're listening to this podcast and interested in medical education, um, Mario will put his fascinating article in the description.
Thank you.
Yeah, there's a kind of violence. There's a kind of violence to it, but what was more interesting for me was, we're both quite interested in Hannah Arendt, and she tends to get a lot of a little bit of shtick amongst philosophers, I've noticed. But when she described the banality of evil, she was describing something quite particular, which was the kind of bureaucratization of cruelty, in a way, the kind of that you could perform something heinous, and not and not have any internal experience of doing something evil, not having to be particularly brainwashed, but that you could just participate passively
Yeah.
in evil.
Just to summarize very quickly for people who are, I mean, most people have heard it probably, but so she was covering the Eichmann Trials, who was one of the, let's say, architects behind the Holocaust.
Yeah, he was in charge of transportation, so the trains.
Yeah, and there's the really great film. I think it's called just Hannah Arendt, which shows this part. It's I really recommend it, but it shows how in that was right after the Second World War. So the prevailing discourse was this is like the epitome of evil. Hitler was already dead, but someone like Eichmann, that's the devil himself. So in the way that she covered the trials and what she wrote about it later, she said, well, it's not so much that he's evil in the sense of like a devil or something like that. It's that he's thoughtless. So he
Yes.
doesn't think. She used this word. I think Amtssprache comes from her. It's like Amtssprache is like bureaucratic language. Just like a link, maybe it's not appropriate, but anyway, a link to scientific research. If you're doing an experiment, you speak about samples and data and all that. It's a way of kind of a technical way of speaking about it. So Eichmann, she said something, well, he was just concerned with having the trains run on time and how many units can you pack in one train and all that. And by speaking it, by using unit, by denying the humanity of, in this case, Jewish people and gypsies and other people, he was able to just do it without not because he hated Jews or something. Maybe he did, I don't know. But in that case, it wasn't even relevant because he was doing calculations. He was speaking about units. He was not responsible because he was just following all the orders, and this was just the system.
Yeah, perfect. I mean, that's exactly what I'm saying. And just if someone's listening and trying to tie together the threads, I don't think I'm really saying that medicine is evil, or that there's something diabolical, bureaucratically evil about medicine. But the interest was just that why do doctors have a capacity for this? Where does it lie, and how does it take a normal person and strip it of its empathy? For someone like I forget his name, Levinas. For Levinas, the basis of an ethical decision, the other, I look into the eye of the other, and the other says, "Thou shalt not kill." That's for Levinas the basis of any ethical decision. That's where he kind of begins. My knowledge of Levinas is a bit shallow, I'll grant that, but how is it that actually in medicine we bypass that? We really do. We do strip people down to a kind of set of functioning organs. We strip them down to a disease, and in some sense, it is humiliating for them. As you said earlier, it's humiliating in the sense that it reminds us that we're finite. Now, to secondarily bureaucratize that, to just completely, engage with that, say this is the process of medicine is not a humiliating process. To be afflicted by a disease is it's secondary. It's it's almost irrelevant to the medical process, because the medical process disregards that, because it needs to continue to efficiently diagnose the disease, to focus on its physical characteristics, to ascertain precisely the extent of it and how it is to progress. That's the focus of medicine. And this kind of any focus on something like an experience of it, or how to relate to it on a personal level, or how to relate to a person on a personal the patient on a personal level, we can simply exclude that.
So you need to do both things as a doctor. So you need to relate to the patient as a human being, a person who is suffering, but at the same time, I mean, your daily job has to do with giving people chemotherapy, which is not a nice experience. So you're performing actions that will make people, let's say, I'm using quotes marks now, sick. In order for them to cure the cancer, right?
Yeah.
But at the same time, you're doing that to a human being. So you need to have the scientific, let's call it the scientific reasoning, logical reasoning, and you also need the empathy.
Yeah, but it's just the question for me was really, so if you're a person on the street and you see a child fall down and smack its teeth on the ground, and you see blood in their mouth, you're not no human being would look at that child and not be able to feel some kind of pain or revulsion or horror, or feel upset, even if they can't put a word to that emotion, and want to help the child. So that's always the image I have, because I remember seeing that on a street corner, and I just remember everyone around me was crying, and the kid was crying a little bit, had a bit of blood in its mouth and a chipped tooth, but everyone was so horrified to see this child in pain. And then when you get into medicine, that side completely disappears. We don't have to tell people on the side of the street, did you see that child? Did you relate to it as a human being? We don't have to do that on the street with people. But when we're in medical education, we suddenly have to remind our medical students, don't forget to see this as a human being.
But I was asking you before, do you, at the end of the day, do you take your experiences home? But how many patients do you see an hour on average?
Oh, absolutely. So no, not too many. So in this job, where I'm currently working with, it's maybe see 2-3 patients an hour. It's slow, difficult work. But when I was working back in South Africa, I would be seeing maybe 6 patients an hour.
Yeah. So there's like dozens of patients every day. If you would have this reaction that you like this to a child falling with every patient, I mean, I don't think you could do that job for very long.
Yeah, I think that's the kind of classical argument, is that empathy is kind of it's a luxury in a way. The kind of really relating to a person on a deep level is a luxury, not everyone has the time and energy to afford. To which I would argue, yes, of course, but we then have to intellectually engage with everything that would be missing, that we would miss. Instead of engaging on an emotional level, we would have to engage with those same things, that same, relating to the other person, understanding their suffering. We'd have to still engage with them on an intellectual level. And that seems to be missing in medicine. There seems to be no pursuit of that. We integrate, we engage very intellectually with the process of disease and the nature of the disease, but we would not be able to engage intellectually with, the nature of the suffering, or the nature of the process that say brought the social process that brought this patient to be where they are. And that's kind of excluded from the intellectual training of doctors. So you're right. If we can't engage it emotionally, we need to argue the importance of that same kind of paradigm on an intellectual level.
Okay, so let me just make some connections with what you just said and some earlier episodes, because it seems to me there's, I don't know if you can call it, two different ways of thinking at play. Like one is like a scientific way, looking at the patient also as a body, almost like how you describe it. In South Africa, a patient would come in and you can see that there are all sorts of social conditions that are at play. They can take a day off work for to take their medication, but when they came to one of your colleagues, it will be like you take a car into the shop and they just open it and they look, what can I see in the car? So that's one way of thinking that is actually behind the success of medicine, probably. And we human beings live much longer than they did before, for a large part also because of this. And the other side is relating to another person as really a person. But then you wouldn't cut another person, you wouldn't give them something that would make them sick. And so that has advantages and it also has disadvantages. And it reminded me, first of all, of, I think we talked about this a long time ago, about Adorno saying that the same kind of thinking that allows you to take distance from another person, which is necessary to survive sometimes, is also the kind of thinking that led, in his case, he was speaking about the Holocaust. So he was struggling with that. He was struggling with this horrible thing happened. We're traumatized. He was traumatized because he was a survivor as well. But then if you don't take distance, you're in it all the time. You can't live your life. But if you have a kind of thinking that allows you to take a distance, so you can, have a more analytical grasp of it, then that is also the kind of thinking that leads to like experiments and everything, because you don't see people as people anymore. And the other connection was to the pharmacon that we spoke about, at least with Daniel Ross. Are you familiar with the pharmacon? The pharmacon, it's a concept. I think it started with Socrates or Plato saying that writing, makes you remember things, but it also makes you forget things. So it's double-sided. Mm-hmm. The thing that makes you want to cure a patient because you care about that patient, but the kind of thinking that helps you cure that patient also makes you forget that it is a patient sometimes. So yeah, anyway, so these are just some connections that came up to previous episodes. So we met, what is it now, like 2 or 3 years ago, I think,
it must have been right just as the lockdowns began.
Yeah. And that's another connection, by the way, because it was in a course by Justin Murphy and Johannes Niederhauser from episode 2. And that's where you gave a presentation that really triggered something in me about, some of the things you've talked about already. Yeah, so can you speak a little bit about that? What were you thinking at the time? What were you occupied with at the time?
Yeah, I think that course was fascinating.
Was about Heidegger and Deleuze.
Heidegger and Deleuze and technology, mostly focusing on, what's the nature of technology. And I think what was particularly interesting for me was I just really started taking Heidegger quite seriously. And I just finished, I think, my first reading of Being and Time, and which was an absolute struggle. But I think what was fascinating there was this view on technology, not as some sort of, embodied in kind of objects, like we all think of technology, specifically computers, laptops, cell phones, the internet, kind of, but really as a way of thinking, that takes like he famously writes, that the same Rhine that Rilke wrote poems about is now a way of producing power in the form of a hydroelectric plant. It's kind of something happens before the appearance of the thing, the technological item that requires you to see a certain how do I say, certain phenomena as a standing reserve, as something that is available, present at hand, something that's available for use.
So the river is not just something to enjoy and to write poems about, but it becomes a source of power that powers a generator, etc.
Yeah. So in essence, what the thinking that was getting me was, why is it that everything that we do, or for it to be real in a way, for it to be in medicine, in medical practice, for something to be real, for something to be necessary, for something to be important, you have to ascribe a kind of usefulness to it. And that rest or a lunch break is useful insofar as you can actually efficiently do your job better. Empathy is useful insofar as it prevents you from getting sued. If the patient thinks you're being empathetic, they won't be quite as likely to sue you. And I think that's really the question that was facing me at the end of that course. And I made a comparison to how I think things really are when we're kind of enmeshed in medicine. And the comparison was really that for the most part, medicine is really participating in this human side of things. We're actually, for the most part, trying to change a patient's behavior. For example, when we're talking about diabetes and diet, we're really trying to impress upon them the importance of healthy eating, lower sugar intake, all these things. And in that, I think the comparison I made was Sherlock Holmes and Watson. That in medical school, and of course, Sir Arthur Conan Doyle was the doctor, and he wrote Sherlock Holmes with this kind of medical thinking that Sherlock Holmes takes all these little bits of data, and because he has this knowledge behind it, the data isn't just something that's empty as it is to the rest of us. It's full. It has kind of meaning to it, and he can ascribe meaning to a tattoo or a tan, a tan of a watch, or famously that the case of the dog in the night, where he's talking to the investigator and he's saying, well, I want to impress, or I want to understand, or I can't remember the exact words, but the curious case of the dog in the night. And the investigator says, well, the dog wasn't barking. And Sherlock Holmes says, that's what's interesting. The dog was not barking. And I think that kind of medical thinking that kind of thinking is medical. That's how we think in medicine, is trying to piece all these things that are and are not there together to form a diagnosis. But that's only one side of it. The other side of the story is Watson, who's kind of looking in on this, and he is a doctor in this case. But he looks in on it in a human way. He still sees Sherlock Holmes as like a person, who is suffering, or he sees the behavior of people, and he's kind of looking in. And I always thought that, or after the course at least, I was thinking, well, Watson is performing the role that a doctor also has to do, relating to other people, communicating, being aware of the world around, formulating everything in a way that's understandable to someone looking in. And I think that was the example that you immediately messaged me about, which we didn't end up using in our paper because we couldn't find a space for it, unfortunately. But I think that's that kind of that was what I was trying to find out, let's say, at that time, was what are these worlds that the doctor finds himself between, and what does it all mean? How do we understand it?
You can see a doctor as a detective trying to solve the mystery of the headache, for instance, or the mystery of the pain in the night. And in that, it has, by the way, Watson, Sherlock Holmes is often used as deduction. There's this famous line from him, like,
when you have eliminated the impossible, whatever remains, however improbable, must be the truth.
Yeah, okay. So that sounds kind of like a doctor could approach a patient, right? Like, you have kind of an idea of how likely, a headache, maybe stress is most likely paracetamol, and come back in a week and see if it's still there. But there are also things like a brain tumor is less likely. But if you've eliminated all the other more likely things, then maybe the less likely thing is there. It's kind of the way of thinking like a detective, right? And are you saying this is how doctors tend to see themselves, and they're missing the Watson figure?
Yeah, I think so. I think, how doctors see themselves, I think is something I'm starting to uncover, and it's not a fun task to do. It can be quite horrible to delve into psychology, especially the Lacanian psychoanalysis. It can be quite disconcerting to see these things like obscenity and enjoyment, and how these all fit into medical practice every day. For instance, why doctors tell such obscene jokes, or why is there obscenity in medical practice? Is it a kind of an outlet for how stressful it is, or is it really some other kind of subjective process at work? But I think at some level we were explicitly taught that we look at where we should be like Sherlock Holmes, seeing things that aren't visible to the symptom, in a way, that the symptom is a kind of just a signifier, just a floating signifier. It could mean anything, but that the doctor sees behind that just floating thing, and really makes it part of a disease, or the absence of a disease. It's precisely something which is not there, which that's it's nothing, don't worry about it, for instance. So that's one part of it. Yeah, I think that was the part that we were really trained to be. But most of the time, doctors aren't sitting and making complicated diagnoses. Most of the time, doctors are sitting, ordering investigations, writing letters, making treatment plans, trying to apply, different forms of knowledge, different means of treatment. It can be quite. It's quite a diverse set of skills, as that little diagram you posted showed. And we spend very little of our time being Sherlock Holmes, and we spend a lot more of our time being Watson, trying to have relationships with other departments, have good relationships with our own department. And that's the interest for me was, exactly that. Why do doctors see themselves as Sherlock Holmes? Because what Sherlock Holmes does, as complicated as it seems, is quite easy in a way, because he just focuses on what's apparent, what are the things that are useful for solving the task.
Yeah.
And Watson's job is quite tricky in that he has to manage the human side of this inhuman machine that is Sherlock Holmes, and make it make sense to all of us from the outside reading it, which is a really difficult task in a way.
And is he also the one? I never read Sherlock Holmes, but is Watson the one that's telling the story?
Yeah, it's
okay.
Watson telling the story.
What can doctors do with this insight?
Well, I'm not sure. That's what I've been trying to figure out. I think being what I'm trying to understand, which has now taken on a historical, more historical view of things, is how this industrialization of medicine, how it's really become quite a formal process, quite a, we need to treat numbers. We need to make sure that we get the most amount of people to live the most amount of time. That this process is going on, that the expansion of medicine is expanding into all sorts of different directions. We just mentioned the COVID lockdown. I think that was the first time I can think of that political powers were kind of ceded to the medical fraternity as a kind of group of experts. The medical industry is becoming quite formidable and has all sorts of different ways of, say, influencing society. If you go on any internet website right now, especially say something like Instagram, you're absolutely bombarded with medical opinions. Use this skin cream.
Don't use sun lotion.
Don't use sun lotion. Don't do this. Avoid the vaccine. Take the vaccine.
Yeah.
All these. Benson is right. Now that cyberspace is in our pockets, medicine is creeping absolutely everywhere. So it was sort of a difficult question to answer, but I think it's important from a philosophical point of view, is to really try and find out how it is that medicine thinks.
Yeah.
What is going on in the mind? What is kept implicit? What cannot be said? What cannot be acknowledged in order for this medical process to go on? Because it's becoming absolutely crucial to understanding the world around us. What's really interesting, which is a kind of something I'm looking at now, is how computing and medicine have a kind of common ground. The theory of cybernetics, that we think of a cardiovascular system as like a perfect circle, and that it has a kind of negative feedback loop. And as soon as that negative feedback loop is disrupted, that it compensates in some way. And a cardiac physiologist would be able to prattle on for hours about the specific curves and how those curves, model onto negative feedback loops. But that's also how we're starting to see politics at the moment, is how the global economy in a way runs in a similar fashion. The heartbeat is sort of the New York Stock Exchange, which pumps out capital, and that capital flows via the arteries of the sea and keeps this whole circuit going.
Oh, I never realized that, but there's a lot of metaphoric language, like a healthy economy. The heartbeat of the middle class is the heartbeat of the economy.
Yeah, it's medicine is not just medicine anymore. So I think that unfortunately a poor junior doctor sitting in the middle of it all is not going to solve all these problems with philosophical thinking. They're not going to say challenge complicated systems. They're not going to suddenly come up with a new way of thinking about disease. But on the other hand, I'm not convinced that we should be encouraging people, make your own small little difference, make sure you're nice to patients, because I think in some way we have to find a very accurate way of dealing with what medical thinking excludes, and a very intellectual way, because we can't fall into a sentimental attitude, just medical practice with just a sprinkling of sentimentality and oh, I'm so sorry to hear that. But what I do think is that it's more a question for senior doctors, more a challenge for senior doctors, I would think, that they start to realize that they're really in a position of power, and that senior doctors need to start to understand that they form very much part of a system, and they need to be very sure that the system they're perpetuating, the system that is either functional or dysfunctional, is serving people in the best way that they can. And ultimately, that's the question I'd like our senior doctors to start asking, not clinical questions, not only diagnostic or treatment questions, but to start looking around them and seeing that they're very much part of something that's not just a disease and treatment set of protocols.
Yeah, so if I hear you correctly, you're saying we need to reconsider what a doctor is and in our time, and ask the question again, which is maybe the philosophical part, because if you just look at the scientific part, science is often seen as an evolution. So we used to, especially in medicine, you can see it. Just in life expectancy, health, they have all these quantifiable measures like health-related quality of life. In general, it's gone up. Of course, we could say a lot about this in globalization, but let's just speak about like the more the countries where healthcare is available for people. It's gone up. So there on the scientific side, you have like maybe a house that you're building. For instance, to take cancer, first we didn't even know what it was. Then at least we started to recognize it. Then now more and more, like you said in the beginning, the life expectancy for someone with a certain type of cancer is going up. And if you follow that line, then at one point, like HIV/AIDS is not, you don't have to die from that anymore. While in the beginning, so that's one way of thinking where we are like getting progressively more enlightened, more knowledgeable about health. The other side of it is that if that is not the whole story, because if that's the whole story, then when you're a junior doctor, you just need to learn that You just need to learn, most importantly, what do we know today? You need a little bit of background about how did we get to learn that, which types of thinking. And you also need to be able, because it's progressing, so you need to be able to basically read scientific articles with new findings. And when the patient comes in, you don't know it, you look in your database and you find out, like a meta review of how effective is this kind of treatment with this kind of disease, right? So this is a whole complicated system in itself. It's not easy, and just medical training is 6 years or something, or it's a long time. And then also when you're a doctor, you need to keep learning, because we make new discoveries. We find out maybe things that we used to think were wrong. But the other side is that you're a doctor in this time, and that may mean something different than a doctor even 10 or 20 years ago. And that's a different kind of thinking. And then we talked about before about Stigler, about obviously the healthcare is closely related to technological innovation. So we are able to do operations now in large part because of the technologies that we have, and we didn't have that, in the Stone Age. Even if we would have the knowledge, we would not be able to do it materially. So, but this technological innovation is speeding up. Before, there was maybe medical innovation every decade or every century or whatever, and now it's like every year we find out more and more. Just look at the corona vaccine, right? How quickly that was. If so much money, so many people are working on it. It's incredible how that is possible. And in large part, it's possible because of technology, but also information technology, exchange of information. But it also means that if you're a senior doctor now who has been practicing for 40 years or something, you're teaching your knowledge and your way of seeing medicine to a junior doctor. But maybe it means that what used to be a doctor when you were doing medical school is not appropriate anymore, in some sense.
Yeah, I would agree with that. I think you're opening up quite a few avenues of discussion with that last point. But I think it's important that as you say, the medicine that we practice now is not the medicine of 20 years ago. Where I trained in South Africa, we're still practicing the medicine of 20 years ago in some way. But when you come to European Academic Center, it's completely different. It's relying heavily on special investigations, radiology. But even then, you could, even in medicine nowadays, you could come up with a treatment plan without ever physically seeing the patient, without actual physical presence. That is something completely new and raises some ethical questions. We brought up exactly Levinas, looking into the eye of the other. That's not necessary anymore. The medical process can go on with just a table of blood results, a series of scans, and someone just going into the room and asking if there's anything new with the patient.
Yeah, especially if you add to that like smart watches and everything that are able to measure heart rate and everything like that remotely.
Yeah, absolutely.
If you want to speak to the patient, you can do like we are doing now over Zoom.
Yeah, exactly. This is it's kind of a dream in some ways that I think we were having in the early 2000s, that we could have these kind of systems that were foolproof, that were just neat, objective, definitions, ascribing perfectly, the nature of the disease and what the only question is what investigation to do next, really.
Yeah, because the doctor is still a person, is subjective, is bias. Bias is a big word in medicine. So what if we can remove the human biased subjective doctor from the equation?
Yeah,
but why? So okay, but why not?
Yeah, well, you could remove everything, but at the end of the day, you're still left with the questions. Well, if we remove everything subjective, we can remove things like hope. We could remove things like ethics in a way. We could, if we can completely unify the well-being of a patient with the best provable treatment, we have no need for ethics, because if I have a disease before me, the only ethical thing to do is try and cure it. And if I have the right treatment that has been ascribed by the data that has been collected extrinsically and objectively and verified, I have no need for ethics. I can just treat the disease. So that's obviously a debatable point, but that's, I think, to some degree, where some doctors' thinking is headed. I would also say that as much as the data is as clean or as reproducible, or new drugs are as safe as we can get them, they are also made by private companies whose incentive is to make the most marketable drug with the fewest amount of side effects. And the long-term effects of drugs, the safety of drugs, don't really enter into the equation, because generally pharmaceutical companies only make substantial profits in the first few years of a drug being made. So really, we don't live in a dream system. The outcomes are owned. Someone owns a stake in these things going well. And
well, that's what we talked about before, HIV medication. I don't know how it is now, but in the Netherlands you get it for free because we have healthcare insurance.
Yeah,
but there's different prices in different parts of the world for medicine.
Yeah,
that in one country it's free if you have this disease, in another country you can only buy it if you're very rich.
Yeah, the question then is, how much does the free medication depend on the profits made in other countries?
Yeah.
These are economic questions that can be quite depressing to look into. How much does the free drug that's given in South Africa, all our HIV drugs are funded by the United States government funds. How much of that depends on the profits made by this pharmaceutical industry and drugs heavily profited from?
Yeah, it's all connected, right? So you were reading philosophy when you were around 14 years old, starting with Nietzsche, which is a nice way to start philosophy. I think Nietzsche for 14 years old, that sounds about right, by the way.
Yeah, it was angsty enough.
Yeah. So he was very negative about Plato, but you didn't know who Plato was, so you started to read that. So did you read the cave allegory as well at that time?
I actually read that quite, further on into my studies. When I was 23 or something.
All right. So were you just, was Nietzsche right, according to 14-year-old you, when you started reading Plato?
No, I think like every critic of every other philosopher, I think there's more to the philosophy. The philosophy undermines the critique more than the critique undermines the philosophy sometimes. Reading Plato after seeing him criticized was much more interesting. And I think, as far as Plato's cave goes, it's difficult to escape. the profundity of the allegory of the cave, because ultimately that's what knowledge wants to do. It wants to understand. It wants to elevate. Human beings want to elevate what they see and find something intelligible and something beautiful and something true about it, rather than just be stuck with the kind of everyday appearances of things. So I would say, I would say the allegory of the cave was closely tied in with what I was trying to understand. Was what is the grounding of medical thinking? Where does it stem from? Where does it say it begins? What are its aims and what are its principles? And if we try and understand that, we can understand where it goes wrong and why it goes wrong, and where its limitations are. So ultimately, the question of empathy for medical students doesn't become, why do medical students lose their empathy through time, but rather, how is it that the loss of empathy is instantiated into medical thinking? Rather that kind of question. And I think that's ultimately the answer to that is the way out of the cave. How is it that this medical thinking is grounded? Did that make sense? That
Yes.
sounded quite stupid.
No. It's just okay. Let me just give you a counterpoint, right? Like, let me give you like a traditional reading of Plato's Cave from, let's say, a medical perspective, where you would say, okay, the shadows are the symptoms. A person has a headache. Then the fire and the statues in front of the fire are maybe like the disease. There's probably technical terms for that, but let's say in this case, it is a brain tumor. And then out of the cave, you find the mechanisms behind. So maybe like the practicing. So us people, we just see the same symptoms. We see people with a headache, people getting sick. The doctors, they see, this is maybe the underlying condition that maybe we can treat. And then outside of the cave are the people who understand mechanisms behind cancer and who are able to find the chemotherapy that works. So this is like the underlying mechanisms, how the body works and everything like that. So you go from the symptoms, the shadows, to reasoning, to the underlying thing. Oh, it must be a brain tumor. And then you go to the science. And then you take this science, you translate it into a treatment, and then the symptoms disappear as well.
Yeah.
So this is, just kind of improvising, but that's kind of a medical reading of that. Do you agree with that reading, or would you read?
Oh no, I don't disagree. I think I'm just interested in something slightly different. I would say the doctors are chained to the wall, looking at all these appearances, as they manifest as diseases, and when we walk out of Plato's cave, I'm not expecting to find a mechanism, some material thing causing the disease.
Yeah.
But I'm interested in how it is that how is it that the thinking illuminates this disease in such a particular way? How is it that we come to ascribe disease in this particular, for instance, the reason halitosis exists is because of the Listerine company. It's not a medical diagnosis. It was invented by the industry to produce sales. Listerine was famously used to treat syphilis at some point. and was just changed to a mouthwash without changing the formula. And they invented halitosis. So, that's what I'm really trying to get at, is what is behind, what are these things that we say are really creating these manifestations of disease? How is it that we ascribe disease to some things and not to others? How is it that we treat depression in the same way as we would treat a cancer, with the same kind of forms of thought? Is it because we're able to ascribe treatments to those diseases, or is it because we're actually very interested in what diseases actually are? Are they all mechanisms? Does a mechanistic way of describing disease suit all diseases in the same way? Or is there something else at work? So really, in essence, if we step out of the cave, we may not find a mechanism. We may not need to. We may find ourselves not having to describe anything mechanistic at all. But we need to step outside the cave to see that.
Yeah, so what you say kind of links to the tendency that the biochemical, like biosocial chemical model, I think it's called. So you look at chemical mechanisms, biological mechanisms, but also increasingly social mechanisms behind disease. Well, a lot of people have criticized that model and are actually also trying to look for alternatives, because it may be useful if you say, well, this is you have symptoms, there's an underlying mechanisms, we need a treatment, and then it goes away. But what if the patient cannot get better? Like in cases of chronic pain, for instance, or chronic non-lethal cancer, so are you then just sick for the rest of your life? Or in the cases of where there's a symptom, but they actually have a term for it. It's called medically unexplained physical symptoms, if I'm correct. So it's when someone has like their arm hurts, but you can't find a mechanism underneath it. You do brain scans, you do all your doctoring stuff. You can find out what it is, but we do recognize that it exists and that many people have this. But the mechanism part is missing. So instead of saying, well, a lot of patients have something that we cannot explain, you say, well, actually, we can explain what they have. They have MUPS, which is the short for, or they have ADHD, or they have depression, or these are different ways of saying, well, constructing something like depression, like it would be like a tumor or something, reifying it.
Yeah, precisely. I mean, that's what medicine is looking to do now. It's absolutely so committed to a material cause for all its understanding of the world, that it can have a mechanism without a mechanism.
Yeah.
We presume that there will be some kind of mechanism, to the degree that we don't even need to know what the mechanism is. And
you're already assuming that if you can find something, then because of what I talked about, the evolution of medicine, there will at one point there's a mechanism that will turn up in the future.
And look, there's nothing wrong or bad about thinking like this. We just need to keep in mind what it is that this way of thinking excludes.
Yeah. So what are some of the philosophers that when things are difficult for you, maybe in South Africa?
So as much as philosophy was particularly interest, I never found it really helpful. If something was terrible, awful that I experienced in medicine, something that really keeps you up at night. For instance, I was working a lot in a gang-ridden area, and I would work a lot in the pediatric emergencies, and so a lot of pediatric gunshots and terrible things, completely horrifying experiences in that sort of part of the world. Philosophy doesn't tend to help all that much. If someone dies horribly or a child is wounded irreparably, there's no philosophy there. So I would say that philosophy begins when we start to try and account for these things and try and to try and understand how this came to pass, what to do about it. That's really where philosophy starts. Not with the wounded child, but really with the person who asks, oh, what are we going to do with this wounded child? I would think that's where philosophy starts. Why, the ideology that takes over, either the pure mechanistic thinking, oh, the child is wounded in these particular ways. Let me try and fix the particular problems that the child has right now, or the political philosophy that would take over, what are the situations that brought this child to be here, or the kind of psychological philosophy, the doctor who tries to make meaning out of this, tries to understand how to deal with this horrible instance. We'd need to examine that philosophically. Unfortunately, philosophy does not tend to be particularly helpful when you're faced with really horrible circumstances, and nor should it. No help there, unfortunately.
So what do you get from reading it, and what are some of the philosophers that you're interested in now?
So I think I really still kept an interest in Nietzsche and Heidegger, and the way Heidegger essentially re-examined the whole history of Western philosophy. That's a cue for us that it is possible to re-understand our entire history of how thinking brought us here, and what it is that we're really thinking. I think that's an important part. Right now, I've been looking more into the beginnings of modern philosophy, Kant and Hegel, and really trying to understand how it is that we need to argue, and how it is that we need to put a case forward for these problems that we face, that for a lot of pre-modern philosophers were sort of taken care of, that God, the figure of God, was the feature of good, all that is good and all that is beneficial, and ultimately all that is. And after this, how Heidegger describes it, the collapse of metaphysics, how we've lost a kind of grounding for our knowledge, a grounds for being, and how philosophy has to investigate those questions and what to do now.
Yeah, I guess we haven't talked about, as far as I can remember, I haven't talked about Nietzsche really in this podcast. So what you just said about we lost the grounding, that's also something that Nietzsche says, right?
Nietzsche says that. I think
where do we find certainty? Where do we find the foothold in, for instance, like in the context of medicine, for where can we find the definition of what health is, so that we know what to do?
I think that I suppose is a Nietzschean question, but I think it's a thread that really runs through so much of modern philosophy. I mean, even through to Marx, of course Hegel, and I mean, it's really Kant Kant with his inspiration from Hume that really started asking, where does this knowledge come from? How do we begin to piece together this thing called knowledge at all? It's a massive series of questions. I think Nietzsche was my way into philosophy, but I must admit I haven't found a space for Nietzsche in understanding medicine and the context where we live in. that well, not as of yet.
You still have time, I guess.
Yeah.
So what do you think for people practicing medicine, what is the, if you have to pick one philosopher, where should they start?
Oh, one philosopher.
Or two, if you want.
Oh, that's a interesting question. I think if anyone was interested, is to really start with, back at the beginning with Plato and Aristotle, and if they can get a grasp on how the Greeks were thinking, and they can if you can understand how the questions the Greeks were asking and how those were important to them for their own sake, not for any particular reason, justification, but really just asking questions. Why are these things here? Why is it that you can really start to see that a lot of these questions in medicine are largely unanswered. We don't know. We assume so much in medicine, and I think if you can see that these questions are alive in medicine, that Plato and Aristotle were answering, asking the real kind of crux of a lot of questions the public is asking the medical fraternity really come alive. I would say Plato and Aristotle is the place to be.
Thank you very much for this journey through medicine and Plato's cave. Yeah, so people should read, speaking of Plato and Aristotle, your chapter in the book Applied Philosophy for Health Professions Education, which is about chronos and kairos.
Yeah, well, I think that was that's an interesting space. I worked with Sven on that one, and if you were interested in medical education from a philosophical perspective, Sven is a really on the edge of some very interesting discussions that are being had. So I think that chapter in your book, I'm sure you can post a link to people below.
Yeah.
That's an interesting look that we had into medicine, but it's quite specific in some ways, and ultimately extraordinarily general in others. So I think I would take a peek in there. It was fun to write, and I think it was just I think what was most fun to write about it was how easy it was to find kind of cracks and crevices that philosophy can occupy in medical education that are absolutely fundamental to the whole process.
Yeah, that chapter is really, without doing it justice, about different conceptions of time for performance, as we spoke about, like efficiency, performance, the time of your calendar, every hour filled with appointments, and the other one is the time for reflection, where you don't have, actually it's free time, it's more like time without a purpose. We talked about it a little bit with Daniel Ross as well, the importance of free time, and with Marcia Björnerud, she wrote this book Timefulness, which also leans on these different conceptions of time. But I guess that's a topic we should get into another time, as the article that we didn't discuss that we wrote together. But we did another podcast about that, so I can just link that.
Yeah, absolutely. I think that that chapter just may deserve its own discussion at some point in the future. Yeah. Probably deserves its own voice.
Great. So let's speak again another time, and thank you for now.
Thanks. Yeah.
Thank you for listening. You can find Camillo's publications in the show notes, as well as a link to another podcast episode in which we discuss our publication Because We Care, a philosophical investigation into the spirit of medical education. Go to livefromplatoscave.com for other episodes and ways to support this independent educational project.